Sir, I'm extremely sorry for the initial delay. The topic which was given to me was auditory outcomes in speech development in post-CI patients using AI. Now, it is a seemingly difficult topic just because there is so less which has been so less has been done worldwide on cochlear implant by using artificial intelligence. But the brighter side is that whatever has been done will be covered in this talk. So this is actually the taxonomy of AI-based applications in CI. It's a very busy slide. It says that it lists out all the applications which can be done by using artificial intelligence in cochlear implants, be it the outcome, technology, programming, and other aspects. Some of it is overlapping with the technology in hearing aids. So we'll come to that later. To simplify this slide, I have divided AI applications into 4 aspects in cochlear implants. First is imaging. Second is speech processor strategies and technologies, which is very similar to AI in hearing aids. Third is programming. And fourth is information dissemination. Coming to the prediction of outcome using imaging. Now, earlier, the outcome, the most important predictors were when the child is implanted, the age of the implant, the age of the child when implant has been done. And second was the residual hearing. And to this effect, a lot of papers have been published, including paper from this very institute. So this is the conventional way of thinking. However, we can see that similar children who have been implanted at the same age, with the same implant, with the same surgeon, with the same environment and same training, the outcome is different. So what can be the other reasons? The answer to this was sought by imaging. And there was a big study which was done in Chicago in collaboration with China, because these US and China are leading in AI, and they did heavily weighted T1 imaging of the brain pre-implant and of children who are not hearing, who have got congenital sensorineural hearing loss less than 3.5 years of age, and compared it with children who are hearing normally. So there were 2 aspects. One was to see how different is the primary auditory cortex between hearing and non-hearing children. And second was to see what is the difference between the secondary auditory cortex and the higher brain, because these are the areas which gets affected later on. So suppose by the age of 3 years, the primary auditory cortex get affected. The higher centers can get affected at the age of 4 years, 5 years, 7 years, maybe 8 years. So if there is a preservation of secondary auditory cortex and higher listening and higher hearing centers, there is a possibility that the outcomes will be better in these children. So how to measure that? So there were 2 aspects. One was to measure the density of the white matter and gray matter, and the other was to measure the morphology or the texture of the neurons which are present in these cortexes. So now we have got 4 variables: primary auditory cortex, secondary auditory cortex, the density, and the morphology. So, and of course, this is diffusion tension imaging. There's no use of AI in this, but I've just put this slide to show the advancement in imaging. So I'll come back to this slide. So in this study, it was shown that secondary auditory cortex play a major role. If it is preserved, the outcomes are better. So it's it's a long study with follow-up of 6.5 years. So it conclusively proves. And second thing which it proves is more than density, the morphology matters. So, I mean, I'll not go into the details of imaging, how density is measured and how morphology is measured, but the take-home message is that imaging can play a major role in predicting the outcome of cochlear implant. Now, imaging can also play a major role in accurate surgical planning. Now, all the company names which are listed here are not because of my vested interest. It's just to show how these companies have progressed in assimilating information and using artificial intelligence to the benefit of the patient. So the Oticon has developed a software known as Nautilus, in which you have to go online and upload the images, and they will send all the measurements, including the 3D images of the cochlea. This will help in a better surgical planning. Similar software has been developed by Medal, which is known as Autoplan. I believe there is a lecture after this about Autoplan. So it also gives you measurements and the 3D imaging of the cochlea. So and this is freely available with the company. You have to send it to the company and they will get back to you with the detailed analysis. This Autoplan software is also used in bone conduction implants. Now, the third most important thing which has been done is Medal has acquired a data set of synchrotron images of cochlea. Now, this data set was assimilated by MITAX, which is a Canadian-based research organization. And you can see the beautiful image of organ of quarter in this. So, synchrotron image is gathered by a synchrotron, which produces enormous amount of data in a day, which is about 10 million gigabytes a day, which is then processed by using AI technology, and it details the finer structures along with color coding of all the inner ear and the temporal bone structures. If you are interested in this, you can go to this link on the YouTube, where some of the images are, obviously not all the images are shared, but most of the images, and you can have a better understanding how an actual cochlea looks like. And it is better than histopathology, because the staining shrinks the delicate membranes of the inner ear, which doesn't happen in this. And even a thinnest of membrane like resonant membrane, which is 3 microns, which is about half a size of RBC, is clearly depicted in these images. So this is, and now the Medal is planning to design the electrodes based on the data set acquired by them. And this was acquired last year. Now coming to the speech processor technology. Now this speech processor technology is aimed at better localization and denoising, which is hearing better in noisy environment. So these are the two main aims. Now, I will not talk about the speech processor, artificial intelligence and machine learning and deep learning, which has been discussed yesterday as well as today. But all these aspects are incorporated when a technology is developed by the various companies, and I'll come to them in detail. So the primary aim is to improve the thresholding, denoising and enhancement and localization. Now, this is one of the popular cochlear implants which is done worldwide, and they have what is known as nucleus smart sound processing technology. So again, the aim is that the person should hear better in a noisy environment, and he should know where the sound is coming from. Medal has claiming of using artificial intelligence in Sonnet 2 with adaptive intelligence, noise reduction, and fine hearing. So I believe it should be the same technology as hearing aids and the cochlear. Advanced Bionic has got, they're promoting a software known as AutoSense 3.0 operating system, which they claim is better than the other two popular implant companies. And there are a few research papers on that, but nothing substantial which has been published in a good journal. So I believe all the three are at par as far as the technology is concerned. Now, what I was interested more is in the future. That is the audio-visual speech recognition. Now, Google has patented this technology. What it does is that not only it denoises, enhances the sound, it also lip reads and make out what a person is speaking in his native language, and the fusion of the auditory input and the visual input is done, and which leads to further enhancement in understanding the speech. So this technology is the future, which can be used by the various implant companies, wherein the patient who is wearing implant focuses on the person who is speaking, and with the aid of visual recognition and auditory perception, better results can be obtained. Now coming to the speech processor programming. Now this is exclusive to the cochlear implant. What is the goal of therapy modulation? I mean, we have to define the therapists and the sessions, more experienced therapists for more difficult patients, and how many sessions are required. Then we have got computer-assisted therapy, which is technically is not artificial intelligence. But we can monitor progress, and course correction can be done with this computer-assisted therapy. Now, when there is a machine learning, then personal treatment strategies can be formulated, and this is artificial intelligence. Now, this was revolutionized by a Belgian We don't know the timeline. We don't know how commercially it will work. So to end my presentation, I would give my thoughts on what should be an ideal AI application in cochlear implants. It should be there should be no surgery involved. It should be easily accessible and it should be very quick. So I'll play a movie clip which will sum up that this should be the ideal AI technology in cochlear implants. Otherwise, gene therapy is the way. Thank you so much. Just yeah. So.
यही हमारी संभावना बढ़ाने और हमारे जिंदा रहने का इकलौता रास्ता है। लेकिन तुम मेरी पर्सनल समझ गया। सिंक कर रहा हूं, बस कुछ देर और।
Thank you. Any questions or comments? Yeah, Venkatesh sir. Mic on. Okay, wonderful presentation. Thank you for all the good information you gave. I have two questions, maybe comments. The first one is a little bit of clarification I need from you on the outcome prediction that you mentioned in the first part of your talk on based on imaging. Would that be standard normal imaging that we do for prior to cochlear implantation, or it is an FRMI that we are going to do? So it is heavily T1 weighted imaging. MRI with bold sequence is not very successful because when you are given when you are doing functional MRI, there is a problem because the patient is under anesthesia, so there is a problem with the maintaining the adequate blood pressure. So the flow of the brain, flow of the blood to the brain is not what you call it as optimal in a normal life. So the physiology changes. So this is a better thing. And the sequence, I don't remember, but it's a heavily T1 weighted image, which can be done in 3 Tesla MRIs. Okay. A follow-up question to that. Are there any objective criteria for assessing the neural thickness that you mentioned already? Yes, sir. So there are two things, MVP and AVNP. I don't know, some radiologist is there. He can expand the form. So MVP measures the thickness and AVNP measures the... And these the data is analyzed by the AI, so it cannot be done by a normal software. So herein There is a there are two softwares, or what you call AI programs. One is known as LOOCH, and other one is SME. I don't know the full form, sir.
Okay.
Which analyzes it and gives the results.
Okay. Very nice. The next question is about the penultimate part of your discussion on gene therapy. Would you feel gene therapy will be effective in all forms of sensory neural deafness? You did mention something about it, but I still feel it may not be effective in all forms of congenital sensory neural deafness. Your thoughts on that? Yeah.
So 90% of the congenital sensory neural hearing loss and 25% of the adult are due to some gene issues. They have addressed only one gene, which is responsible for 7 to 8%. But if the other genes, now I forgot to mention, or probably I omitted because it was not my topic, but the other genes are too long to be assimilated in one vector. So now they're splitting up those genes and inserting with two vectors, and they will join when they go inside. Something to that effect. So they're working on genes which are longer and which can be, So in future, I think all the genes can be addressed theoretically, sir.
Okay. Thank you.
Yeah, Dr. Vikas.
So Jain sir. Sir, it's not really a query, but a curiosity. As in when this artificial intelligence in CI comes in, will this be backward compatible? What about the millions of children who've already been implanted? Are they going to benefit out of it?
They should, except for the part where a placement is required, where you do segmentation of the cochlea and do the electrode placement as per pitch and place. With the other part should be backwardly compatible, because everything which has been done is in the processor. So if they tweak the process settings to be compatible with the older version of the implants, unless and until they have got some commercial interest in say that it is not, that should not be a very major concern, according to me, but I'm not sure about that.
Yeah, just another comment and then we go to Dr. Rahim. Yes, madam.
All the processing is in a speech processor. So if artificial intelligence comes into the speech processor, definitely we can change it. There won't be any problem in adjusting that.
Dr. Rahim.
So coming to the imaging part of the thing. So basically, if I have to put it in very simple words, there is nothing but perfusion MRI. So the terms like MTT and what you talk, basically we were looking at the perfusion of that area. And the second is like that SMV is nothing but support vector machine, SVMs. So they are a type of machine learning algorithms, which basically classifiers instead of a simple linear regression linear classifiers. Support vector machines have one positive plane and negative plane. So it's basically they are better classifiers to classify your data into various classes. Yes, sir. And as far as that part of where backward compatibility of these things are coming up, like as Himanshu sir has said, right now one area where AI is targeting is to sort of make the placement correct. So whereas the circuitry more or less remains the same, so it should work. Second is like now we are trying to use AI to sort of refine the output of the cochlear implants. So it would sort of as an enhancement rather than it will break the original circuit. So it should work, sir.
Thank you. Any other questions? I think, yeah.
A quick query. This is regarding your sort of curious prediction that there is a potential that in the years to come, probably all this would look very historic once the gene therapy comes, and it's only a question of time that they get better vectors to put in more genetic material inside. What would be your timeline be at the way at which it is going in the last probably a decade or so?
Sir, if you have asked this question about a year ago, I would have said not before 2050. because that was the prediction, 30 years, 25 to 30 years. But after these trials and the way these pharmaceutical companies are heavily investing in these trials, and the results which are shown after a month, like patient can hear after a month. So it's a very short period. You don't have to go for a very long-term study. Of course, if the human trials are done, then it will be long-term. So if the second phase trial starts next year, and then third phase trial another year, so I'd say around 5-6 years on an optimistic side. But it depends again. This is only for autophagy. So
One of the genes only.
so other genes will require more, and I don't know about the costs. So cost might be prohibitive. Depends on a lot of factors.
One last question. Did it occur to you as to why is that there are two subsets of patients, one in whom the primary auditory cortex works well and secondary cortex works well, and in some, the secondary auditory cortex, which actually wraps around the primary auditory cortex, that Broadband 22 area, that doesn't work, but the primary works. Because as you said, that initial studies actually suggest that probably better results can be obtained if the secondary cortex becomes as active. Why should there be such a very closely related two areas? One doesn't work and the other works.
So there are two hypotheses. One is neural recycling, and the other is neural regeneration. So the first hypothesis suggests that primary auditory cortex is recycled, and therefore, if certain age is crossed, nothing can be done about it. Whereas the second theory, which is the hypothesis of regeneration, focuses on the secondary auditory cortex, which get affected at a later age, and that age is variable. So nowadays, like if you really at the moment, we can use N1 waveform by using SERA, which more or less is not present after 7 years of age. But this is more like hands-on and more, it has got a more predictive value, which has been proven with studies that the secondary auditory cortex and the morphology, these two are more important in predicting the outcomes rather than the primary auditory cortex and the density, as per the study.
Yeah. As you can see, a lot of CI and hearing aids, for that matter, and any other assistant listening devices, they have a lot of, they are very heavily bioengineered devices with a lot of investments needed and a lot of collaborative efforts needed by the industry to generally have these products. So to that extent, we are probably the consumers of AI or consumers of technology here. In what way can ENT surgeon be part of this AI revolution other than just being a consumer of this technology?
Yes, sir. So I will zoom out and we look at the country at first. We will lag behind in AI technology because AI technology is not like an appliance like a fridge, AC, or TV, which can be used anywhere in the world. So there is an input of psychoacoustic tests, which are in a certain language. So if we are not developing those things in India in our regional languages, which are also multiple, there is no way that we can make use of this technology. And the second question is, how as ENT surgeon we can, of course, we cannot develop the technology, but we can only be the data providers. And the role of the speech therapist and audiologist will be very important in developing the tests which are standard, which are suitable, and which can be replicated in various languages that we have. So I find it very difficult. Most of the work which has been done in AI is in US and China, mainly in China. And for gene therapies, mainly Europe and US. So
I think you bring a very valid point. What's very important is to have the data being generated in a standardized format, which is more adaptable to the local population. Because ultimately the programming and the devices and this will be made by the industry and not by the surgeon. So, but that data needs to be generated in the correct way and collaborated. I think that's one more final comment, sir.
See, now the generative AI is able to translate almost into 23 different languages. And most likely in a year or two, almost 150 languages would be translatable and be added. Would that solve a problem to a certain extent if Indian data scientists work on this and create mechanisms where regional languages can be translatable to machine learning languages?
So that will only solve the acoustic part of the psychoacoustic test. NLP works well with translating the language, but in what context? Like a child in India might not know, for example, what is skiing in Europe. He's never seen that. So, I mean, just cut, copy, paste, and translating will require some amount of effort will be required from our side also. Like half of the job can be done, but some amount will be required.
I think there's a lot of discussion and there's one more hand raised. Okay, final point. Yeah.
So just adding on to what General Venkatesa said, there is a lot of work going on where we are trying to convert these large language models like GPT into, there are two broad sets. One is Indic LLMs. That means LLMs which are more suited for Indian languages. So if you know, Ola is already working on it. There's something called as Krutrim, the LLMs which are in Indian languages. The second line is where we are trying to create LLMs for the clinical, that is healthcare specialty. Like if I have to give an example, Google has MedPalm. Now they come with MedPalm 2. So it's like two, and a point will come where these clinical LLMs will merge with these language-specific LLMs and will come up with something which will say, which works in say Marathi population for ENT set. So we will get more and more these kind of sets. That is one approach. Second approach is what we are trying to do is what we call as RAGs. That is retrieval augmented generation. That means we pick up the LLM model, or you can say pre-trained GPT, and we have our own institutional data set. Like I have our own clinical profiles or the interactions with the patients. I will not share this data with anybody else. I'll take that model. I'll say whatever output you are generating, please ground it onto this data set. So that is what is RAGs. So this is another way where we can address this kind of problems which are nuanced and specific to a specialty or a specific problem which is there.
Thank you. Very interesting. Very interesting. I'm sure we'll be having better mix of both, translating those models as well as having our own acoustic sort of inputs and data